Good morning, good day. I made a series of presentations on why we need to think beyond the usual surgical diagnosis and how the microbiologists and the pathologists help us to arrive at the correct diagnosis. So this is a deep-seated fungal infections that involve the visceral parts and they present to the surgeon. Now, what surgeon will think of? He will think of malignancy, some stricture, or a few things which is everyday work for him. But there are times when you need to think beyond. So this is in collaboration with Professor M.N. Rajesh. He's HOD pathology in Japan now, and Professor Reba ma'am, who is former editor-in-chief of the Indian Journal of Medical Microbiology. So getting straight away into the case capsule, there are a lot of learning points here which will be presented as fragments in your NEET exam. And when you remember pieces of information, you're likely to forget them. So these are cases, real-time scenarios which are happening, but only what is essential for NEET or your fellowship exams or your OSCEs, I'm trying to give emphasis. As is usual, this is my disclaimer and disclaimer slide. All the collections are from my personal collection. In fact, this case report was published some years back. And as I keep repeating, this should not be an alternative to patient interaction. So this is about a swelling in the right side of the neck in a diabetic patient, and it was mimicking tuberculosis. That ultimately proved to be subcutaneous zygomycosis. So you need a very high degree of suspicion, especially in areas where you're likely to find nodes. So granuloma from a TB and granuloma from a fungal infection can get mutually mistaken. And the most common will be tuberculosis. We will start empirical TB treatment, anti-TB treatment. Now, this case is being presented not only because of its rarity, but to emphasize the role of early diagnosis. And how will you do early diagnosis? By having a high degree of suspicion and by making a thorough clinical examination and appropriate treatment to prevent complications due to proximity to major structures. You will hardly find TB lymph nodes rupturing into the carotid or engulfing the carotid. But when it comes to a soft tissue fungal infection, it has the capacity to be locally invasive. It's not malignancy, but it can be locally invasive. Okay, now you got a lot of clues that this is something more than lymph nodes. So you are now trying to get some imaging to help you out. And the best imaging for soft tissue will be your MRI more than your CT scan. So we have asked for an MRI. Let me show you the structures first. This is your trachea. This is your esophagus. Simple. And this is your spine. You know the cervical vertebrae is here. And then you see, let's have a look. There is a diffuse soft tissue mass here. Not only that, you see it is going like a cotton wool. See. In fact, there is no boundary. I am trying to draw some boundary here. You see, it is insinuating between the tissue spaces also. And also infiltrating the muscle. This is your posterior muscle, which is your trapezius. See how diffuse the whole mass is, and it's quite close to the carotid. See here, diffuse, no tissue planes available there. Whereas here you see the tissue planes so well marked. These are the muscles of the neck, of the back of the neck. You can see the intermuscular planes well. When there is a diffuse mass like this is likely to be a fungal infection of the subcutaneous tissues. Now, the very fact he had a stridor, you can pick up this findings. You see the engulfment around the airway. Now, this engulfment as such will not cause a stridor, but because the pathology is so close to the trachea, it will cause edema of the tracheal mucosa and there is a stridor. So now when you suspect a fungal infection, you need to do a biopsy next. One, for histopathology, and number two, that biopsy itself can be stained for fungus, and number two, it can be even, the tissue can be even cultured for a fungus if possible. So in this area, where do you take a biopsy? Try to move away from important structures of the neck. Important structures of the neck, anterior triangle will be the vessels and vagus. Posterior triangle will be your spinal accessory, only these things. So what do? You even avoid the posterior triangle. See, this is the back side. I have even avoided the posterior triangle and straight gone on to the nape of the neck itself so that I can take a deep biopsy. So the biopsy is deep, not only that, it is safe. So any fungal infection, subcutaneous fungal infection, you want to take a deep biopsy. Avoid the important structures as much as possible. So we have never in the anterior triangle. I'm even lucky I didn't even go to the posterior triangle. I went back into the chest wall on the posterior aspect. So that's a safe area. That showed fungal hyphae typical of zygomycosis and confirmed by silver staining. We'll come to it now. So this is your histopathology. You can see the hyphae. They are broad and non-septate. And if you enlarge your diagram, you can see some eosinophilic material. As I told you, splendor Hopley phenomenon may not be that marked in all your specimens. So that is your hyphae. And then when you do the special staining, which is Gomori methanamine silver stain, the wall will take up nicely. So the special stain for mucormycosis is Gomori methanamine silver stain. So it shows extensive necrosis, and not only that, the hyphae are taking up, and you can see the eosinophilic material, which is a splendor Hopley. Now your splendor Hopley need not happen only in fungal infections. If they are only around inert organisms, like the fungus had died, or the bacteria has died, or the virus has died. So it is intense eosinophilic reaction. I have told this in detail in the previous episode on Basidiobulus ranarum. So what is the Gomori methanamine silver stain? You can make out that the walls are nicely taking up. They are very broad septae. They are not the thin septae. not the thin hyphae, and there is hardly any septations inside. Otherwise, you'll find very nice clear-cut septations. And then look at this. Culture was repeatedly negative because Mucor is such a species that only 50% can be cultured, unlike your Basidiobolus, where it easily grew on the suborats agar medium. So repeated culture was negative. Now what did we do? We still started off on antifungal. You cannot wait for confirmatory culture because it's positive only in 50%. The mycelia have to be really teased out. There are a lot of techniques involved before you get a positive culture. So we have started on oral fluconazole. Even though ideal is amphotericin B. So you realize the mismatch between your ideal treatment and what is practically available. The same thing in an MCQ, you will automatically tick amphotericin B. But when it comes to the hospital, he is able to get only fluconazole. Now, we are not blaming the system. We are not going into that pathway at all. But what I am telling you is, yes, there is an ideal treatment in your MCQs, and yes, there is a practical treatment when it comes to real patient situations. For all you know, you may not have the drug available, patient cannot pay, he may develop severe complications, he may have renal impairment, you may not be able to give amphotericin B. So ideal treatment is amphotericin B, but whether it is appropriate in this patient, not appropriate because not available, not appropriate because he cannot buy, or it may be not appropriate because he's having borderline renal failure. So if you keep all this in mind, you will be able to have your plan A, B, C for the drug list ready. So we have started him on fluconazole, and within 2-3 weeks we started finding the improvement. And at the end of 6 months, see this, at the end of 6 weeks, sorry, look at this swelling and look here. It has almost reduced, except for some few sinuses are there and some induration is there. This will take a long time to disappear. More than that, patient will not be compliant. The moment the immediate problem is solved, they will not stop taking the drug for whatever reason. We are not blaming anybody here. So this is the idea of follow-up. They need to come back to you. You need to keep in touch with them. In fact, I even wrote a small postcard. Just a postcard. About 10-15 years ago, we used to get that 25 paise postcards. I wrote on that and called him back. And he came. When you write a small postcard, they are the first ones to be in the hospital. Don't think they are not complained because of attitude. They are not complained because of the social circumstances. As I told you, these lesions, they will be near major blood vessels. You have the carotid here. You are not going to mess up there. So whether surgery is indicated as part of debridement, no, you're very close to the vessels. Now what will happen? This can get disseminated through the smaller vessels. That is a possibility. Or so it can become a fungal septicemia. Or it can form abscesses in target organs. Or it can even lead to a severe necrotizing fasciitis of the skin and subcutaneous tissue. So things can escalate. That is why we do not wait for culture. You give a reasonable time. No need to wait forever saying I'm going to get the culture, then start on antifungal treatment. So here we had enough clues. One, we ruled out TB. Second, we ruled out secondaries by doing complete examination of the drainage areas like your endoscopy, your clinical examination. Third, we had an MRI picture with us which told us that this is a soft tissue issue and going all over in a very vague fashion. With all this, and then with the Gomori stain, we also managed to get the hyphae there. We were able to start antifungal treatment. So this is very important. Previously, this patient was treated for 6 weeks as a case of TB lymphadenitis. I don't blame them because they've done an FNA and it will obviously show a granuloma. So this is the detailed scientific classification. The kingdom is fungi, the genus is Rhizopus, and the species is Oryzae. Now, zygomycosis, they are from organisms which belong to the class of Zygomycosis, and the order is Mucorales and Rhizopus species. There is a steady increase in India, especially with the COVID. There were plenty of incidents about the mucormycosis of the maxilla, of the frontal sinuses, of the lungs, of the brain. Now, unlike other filamentous fungi, which usually attack immunocompromised hosts, these will be attacking relatively okay immunocompetent individuals, except for some diabetes, where the association is very high. And the types are rhinocerebral, pulmonary, gastrointestinal, cutaneous, and even bone sometimes. The cutaneous form can be confined to the subcutaneous tissue. It can invade muscle, tendon, we had seen in the MRI. Or it can even go to involve the viscera. The disease will be gradual and slowly progressive, or it can even turn fulminant, leading to gangrene and even death. The extremities are commonly involved in the subcutaneous type and rarely the neck. And biopsy, what do you find? Predominantly aseptate hyphae. That is important, and it is confirmed with silver stain. Now, they are composed of two orders, Mucorales and Entomophthalales, and their biopsy is easily differentiating. We will not go into too much detail. Now, coming to antifungal therapy, you don't wait for culture. Start 7 to 8 days therapy and control of the diabetes, or if he is on steroids. Now, the prognosis in cutaneous is much better than your pulmonary or your maxillary mucormycosis, but there is still a recurrence rate. That is why you must call them for follow-up. Inevitable fatal outcome for initiation of antifungal therapy without waiting for culture reports. So do not wait for the inevitable fatal outcomes. Start the antifungal therapy. So a physician's early suspicion of Mucorales infection goes a long way in preventing this inevitable and unwanted morbidity and mortality, and not to wait for culture report. What is the take-home message? Mucormycosis is on the rise in India, especially during the COVID times. We are talking about the maxillary one. Even the cutaneous one is on the rise. Unlike other fungi, it affects the relatively better immunocompetent host like your diabetes. Our patient was a diabetic. In fact, the diabetics was diagnosed only because he came for this swelling in the neck. And the classic features are aseptate hyphae, and silver stain is confirmatory. You need a high degree of clinical suspicion that can prevent morbidity and mortality, as only 50% of cultures are positive. So do not wait for culture positivity to start on treatment. And surgery has not much big role to play unless it is rapidly spreading locally, like in your mucormycosis in the COVID times. Then only you need to do a debridement. Otherwise, most of them will settle down, especially the cutaneous ones will settle down with antifungal therapy. Thank you. So thank you. Please do share and subscribe my YouTube channel, recommend it to your friends, and keep a tab on my Telegram channel also, because questions, the moment the presentation is made on the YouTube, corresponding quiz program or multiple choice is also uploaded into the Telegram channel. Thank you, Reba ma'am, and thank you, Rajesh.